we have Dr. Malcolm Dick, who's the senior neuropsychologist with UCI Mind and has been with us for 30 years. We also have Dr. Cordula Dick-Muehlke, who is the consultant in aging and dementia for Cordula Cares. So without further ado, I wanted to welcome our speakers up for the Family Education Workshop. Thank you.
Thank you so much. Good morning, everybody. We've got a lot to cover this morning. We'll try to take a short break about halfway through. We're going to talk about how you identify, treat, and reduce your risk for Alzheimer's disease. So here's a little bit about us. Malcolm, who's also my husband. Some people think because of our names he's my brother, so I just want to get that straightened out from the beginning. He's my husband. We were so fortunate to meet because of our mutual interest in Alzheimer's disease, and as Kirsten said, he's with the UCI Mind Alzheimer's Disease Research Clinic for the past 30 years. We're both psychologists, and I, in addition to consulting, am affiliated with UCI and was proud to be executive director of Alzheimer's Family Center over there for 17 years of my career. All right, we are going to start with a little fun and see how many of these individuals you recognize. I'll tell you right off the bat, all of them have died of Alzheimer's disease. So let's start easy and work our way across the top. Reagan, absolutely. Who's this? Come on.
He's a comedian.
This one right here. Shelley Berman, very good. Jack Lord, I heard it. Pat what? Kentucky coach? Pat Summit, yes. Over here on the far right. Pat O'Brien, yeah. Whoops. And then going down here. Oh, Sugar Ray. Yeah. Moving over, we've got, who have we got here, everybody? Good job. Who's this? Yep. Who's this? Yeah, good. All right. Yeah, Columbo fame. Do you know her name? Most people recognize her because she was on Bewitched. That's where I know her from. Her name is probably not as commonly known. Her name is Mabel Albertson. All right, let's move down here then and see next to Sugar Ray also. Yeah, good job. Yeah, Glenn Campbell. Does anybody know? Star Trek. Yeah, Star Trek. All right. He's pretty well known for his character, but his name is probably a little less well known. His last name is Doohan, James Doohan. So, and he was Scotty, right? This one? Shriver, Sergeant Shriver, yeah. Jimmy Stewart, Gene Barry. Yep, here we go. Who's this? Yep, Charlton Heston. I don't hear that yet. Who said it? Rockwell. Yeah, Norman Rockwell. Who's this over here? Omar Sharif. And who's this? Yeah, Arlene Francis. So, Alzheimer's disease knows no bounds. It knows no bounds. Celebrity status doesn't protect you from it. We are all vulnerable to Alzheimer's disease. So today in the United States, there's 5.7 million Americans affected by Alzheimer's disease. 5.5 of those are over age 65. And you're going to hear how age is a risk factor for the disease in just a little bit. By just 2030, which is a mere 12 years away, the number of people affected by Alzheimer's disease is expected to grow to 8.4 million here in the United States, which is a 53% increase. Every 65 seconds, the clock ticks, another person develops the disease, and we're going to be together for a couple of hours, so that means another 120 ticks, people who have developed Alzheimer's disease. One of the most remarkable numbers on this slide to me is 16.1 million caregivers. So if you do the math, there are 3 close family members or friends involved in the care of every one person with this disease. So it is currently the 6th leading cause of death and has a tremendous cost to our society, $277 billion. That only represents medical costs. It doesn't represent all the out-of-pocket costs that families pay. So we're just talking about Medicare, Medi-Cal, long-term care costs.
So if we look into the future, this graph sort of shows what to expect. And the whole, across the world, we have an aging population. And right now we're at that 5.7 million, but by 2050, the estimated total is going to be almost triple that number. Estimates close to 14 to 16 million cases. And a lot of this is due to the aging of the baby boomers. These are people born 1946 through 64, who many of them are now turning 65. In fact, just by 2030, it's estimated 20% of the U.S. population will be above age 65.
So here in California, you can see 650,000 Californians are currently affected. By 2025, again, a mere 7 years away, we're going to see almost a 30% increase to 840,000 individuals. Again, triple the number of caregivers. We're the 3rd leading cause of death here in California. And as Malcolm referred to, baby boomers are coming of age, of senior age, and so we know that I, for example, as a baby boomer, have a 1 in 8 chance of developing Alzheimer's disease.
When you look at the actual causes of death for a variety of different illnesses, what you can see is that because of advances in the medical field, early detection and treatment, the death rates for various diseases such as breast cancer, prostate cancer, heart disease, and stroke is actually declining. But Alzheimer's disease has shown this dramatic increase, 123% increase. Part of this is probably related to the new way that death certificates are filled out. In the past, the death certificate would only have the acute or the immediate cause of death. So you could have an individual who's in a nursing home who has been with advanced dementia for many years who dies of pneumonia, and the death certificate would list just pneumonia as a cause of death. But in the last 5 years or more, all causes of death have to be placed. So pneumonia would be listed as the acute cause, but advanced Alzheimer's disease would also be listed. And this has allowed us to have a much more accurate tally of the total cost of Alzheimer's disease. And so when you look at the difference between the immediate cause and people who die with Alzheimer's disease and dementia, what you see is that essentially 1 out of every 3 seniors who die will die with Alzheimer's disease or another form of dementia. And that number for 2018 is estimated to be about 700,000 individuals will die this year with this disease.
All right, let's get back to the issue of caregiving. I mentioned these numbers briefly before, but here you can see 16 million caregivers in the United States. Look at that amount of care. 18.4 billion hours of care valued at $232 billion. Here in California, you see these same numbers. These numbers reflect the impact on families. In California, 1.6 million caregivers, 1.8 billion hours of care, $23 billion in value. And this is something we need to pay attention to. Caregivers, due to the stress of caregiving, are at higher risk for both physical and mental health problems, be it they're more susceptible to getting the flu or they're more susceptible to becoming depressed or developing any variety of conditions. So you can see the great increase in healthcare costs. Families are diverse. We have spouses and children and friends caring for people with Alzheimer's disease. So we're going to talk just briefly here about the risk factors. We're going to actually be coming back in the next slides and talk about these risks that you can't change, the ones that we're just stuck with. How old we are, our genetic profiles, family history, our gender, with women being more at risk, and having Down syndrome. Later on in the presentation, we're going to talk about what you can do to reduce your risk. So we're going to be talking about all of these medical and lifestyle factors, things that you can really do something about to reduce your risk for Alzheimer's disease and other serious health conditions.
The risk reduction, which is the focus of the latter part, is really important because we showed you an earlier slide that said we're going to see a tripling of the number of cases. Well, a lot of research has shown that if people follow those lifestyle factors, the number of Alzheimer's cases could be reduced by more than a third just through lifestyle changes.
So here we go, age. The older we get, the more at risk we are. If you're between 65 and 74, about 3% of people are affected, so about 1 in 20. If you're between 75 and 84, about 17% are affected, 3 to 4 people out of 20. By the time you reach 85, about a third of individuals are affected, or even more. So that'd be like 6 or 7 out of 20. By age 90, half of people are affected with the disease. And if you reach the age of 100, estimates are that 75% of people are affected. But remember, not everyone is affected. So it's not just a process related to age, it's a disease. So bottom line, about 1 in 10 people over age 65 have Alzheimer's disease.
So in addition to age, gender plays a role. And this slide shows an individual's lifetime risk of developing the disease. So what this means is this is the probability that a healthy individual at any given age will develop Alzheimer's disease during the remaining of their life. And if you look at a woman who is age 45, the probability she will develop Alzheimer's disease during the remainder of his life is about 19.5%. When you look at a 65-year-old woman, it is around 21%. So in essence, with women, it's about a 1 in 5 chance that they will develop Alzheimer's disease during the remainder of their life. That's about double what you see with men, where it's essentially about 1 in 10.
Okay, so now let's talk about genetics. Well, there are 2 types of genes. There are what we call deterministic genes. So if you have that gene, you will get the disease. And any children you bear would have a 50% chance of getting the disease. Then there are susceptibility genes. Those are genes that we have that increase our risk, but we don't necessarily develop the disease. It's not a fait accompli. So if we look at this slide, we see that there are 3 deterministic genes involved in Alzheimer's disease: the amyloid precursor protein, which, going back to Down syndrome, it is located on chromosome 21. People with Down syndrome have an extra copy of this, which leads to more production of a toxic protein called beta amyloid. There are what are called the presenilin genes, 1 and 2. And usually if you have one of these genes, you have the disease before age 65. So, but bottom line, all 3 of these deterministic genes only account for 1 to 2% of all the cases of Alzheimer's disease. The vast majority of Alzheimer's disease, 95% or more, is what we call sporadic. It's random. We do not yet know what causes it. We know some of the mechanisms involved, but we don't know the cause. And so the most common susceptibility gene, and the one you may have read about in the media, is ApoE4. We're going to talk about that a little bit more. It's involved in cholesterol transport. And about 31% to 60% of people with Alzheimer's disease have this particular gene. And so here you can see, as I said, it's involved in cholesterol transport, and it comes in 3 variants, or what we call alleles. So there's an ApoE2, an ApoE3, and an ApoE4. ApoE2 is the least common. It's pretty rare. Only about 0.5% of the population has that, and this combination appears to lower your risk. And ApoE3 is the most common form, and about 61% of the population has that. And then 1 or 2 ApoE4s are seen in about 25% of the population, yet 30 to 60% of people with Alzheimer's disease. So you, in order to understand this, also I just want to mention again, 30 to 60% of AD patients have this gene. But what does that mean? That means that 40 to 70% don't have it. So you have the gene and could make you more susceptible, but you might not have the gene and you might still develop Alzheimer's disease, right? It's a susceptibility gene. So basically, what the research shows is that if you have 1 E4, you are at about 4 times greater risk. And this risk is greater in women than it is in men. So gender seems to play a role here. And if you have 2 E4s, you can see that you're at 10 times the risk of developing the disease. We want to just mention testing, because a very common question that we get is, should I go out and get tested, or should I go to 23andMe and get tested and find out if I have this gene? Well, there's a couple issues here. Number one is, even if you did find out you had either 1 or 2 copies of ApoE4, I can't tell you to do anything about it. There's nothing we can do to take away your ApoE4 gene. And there's nothing I can tell you that I wouldn't tell anybody else in terms of reducing your risk. The second thing about that is that you really don't want that in your medical record. You could affect your eligibility for insurance, for long-term care insurance, for example. So at this point, we don't really have a reason, therapeutic or otherwise, to go out and get tested for this gene. So let's talk a little bit about how the brain changes and the type of changes that occur in the brain and how this leads to the destruction of brain cells.
So this is just a cartoon of a model of the human brain. And I always find bringing my brain, or at least a plastic version of it, is helpful. And this...
Is that where it went? You asked for it.
I did. And this model is about twice the size of a real brain. As shown in the slide, a real brain is more about the size of a medium cauliflower that you could hold in your hand, and it would probably weigh about 2.5 to 3 pounds in the average older adult. And although it's small, it's only about 2% of our total body weight. The human brain is tremendously complex. There's no computer that can rival it. Within that 3-pound structure, we have about 100 billion cells. And each of those nerve cells has support cells called glial cells, and there's probably 100, for each nerve cell, there's probably 10 to 100 other glial cells. So you end up having well over 1 trillion cells in that cauliflower-sized structure. Alzheimer's disease doesn't affect the whole brain. There are specific areas that are affected first, and they involve this area along the side of your head, just sort of above your ears, called the temporal lobe. And there's a structure inside the middle of the temporal lobe called the hippocampus. Hippocampus is Latin for seahorse because it has sort of a seahorse shape when you look at it from a cross-sectional view. But this hippocampus is the part of the brain that's really sort of our memory storage center. And any damage to the hippocampus on either the left or the right temporal lobe is going to greatly impair our ability to learn and remember new information. Old information that has already been processed through the hippocampus has been sent on for storage elsewhere in the brain. So that's why old information, memories from the past, are retained, but the ability to form new memories of what you just ate 30 minutes ago or who you talked to, that has to go through the hippocampus to be able to form into a new memory to be later sent elsewhere. So Alzheimer's disease sort of follows a particular pattern in the majority of cases. And that's why we see a particular pattern of memory loss is usually the initial symptom. And then as the disease spreads elsewhere in the brain into the back, which is called the parietal lobes, you get language and visual spatial difficulties. And then eventually it goes into the frontal lobes, which are involved in what is called executive skills like planning, judgment, reasoning. So memory might be the first, but then later on other cognitive abilities kick in. Well, what is causing all of these changes?
All right, here we go. So this is an illustration again that shows you the difference between healthy brain cells or neurons. And so you can see that each brain cell has a body and branches that come out. And you see that these brain cells actually don't touch, but the branches come very close, and there's these little gaps. They're called synapses. And an electrical charge will come down one brain cell, and there are chemicals, we'll talk about some of them a little bit. Here are neurotransmitters that facilitate the transmission of the electrical impulse across this gap to the next cell, and that's how the cells in the brain communicate with each other. Now, if you look at this illustration of a brain that's damaged by Alzheimer's disease, you'll see two different things happening. You'll see these senile plaques. They look like tumbleweeds. They're actually collections of this toxic protein, beta amyloid, that I mentioned before. It stays in the brain, collects around the outside of the cell, and you can see how it destroys the branches so that they shrivel up. Well, the theory is that as these plaques form, they sicken the cell, and there's another protein, tau, that malfunctions inside the cell, and turns the inside of the cell, which there are a lot of complex structures inside the cell as well, but breaks all those down, and they turn into this twisted tangle of what looks like threads or fibers. And so you can see this sickened cell as compared to the healthy cell. And these are called neurofibrillary tangles. So you'll see them here in real life in just a moment. Here's, at autopsy, a brain, and this is of a healthy person. So you've seen the side view of the brain already, so you know this is the temporal lobe right there. Whoops, excuse me. This is the temporal lobe. And you can see how all the folds in the brain are nice and tight. And here, when we look at this brain of a person with Alzheimer's disease at autopsy, you can see all the widening, which represents atrophy or shrinkage. And in this person, you can see it in the temporal lobe and the parietal lobe, which Malcolm mentioned, as well as the frontal lobe. So we'll look at the brain tissue a little closer. This is healthy brain tissue at autopsy under a microscope. So here you see those plaques, all right? That accumulation of that sticky beta amyloid around the cell. And it's breaking down the branches of the cell, as the illustration shows. And here you see these flame-like projections, and they are the neurofibrillary tangles. And they interfere with transportation systems inside the cell. So you can see an illustration of those as well.
So we don't really understand how Alzheimer's disease occurs, what is the cause, but the belief is that these amyloid fragments that we all have start to form into these clumps, the little tangleweeds.
The plaques.
The plaques, and these are the amyloid plaques. Over time, as these plaques occur in the brain, they start to make the cell sick, and we don't know why. It could be inflammatory processes or something else, but then you start to see these tangles forming inside the cell, and the tangles essentially kill the cell. So the idea is that what is killing the cell? Well, the trigger is the amyloid. The bullet that actually kills the cell is the tangle. So there's this sort of cascading process that takes place, leading ultimately to the death of the cell. Well, one of the big advances in the last 10 years has been the discovery that we can actually measure amyloid and tangles in a living individual. Before, you had to wait until the person was deceased, do an autopsy of the brain, and then you could detect the tangles and plaques. Well, now, through various methods, we can see that in a living individual. And these amyloid plaques and tau tangles, amyloid and tau are called biomarkers. And we have many biomarkers in medicine. So, for example, when the doctor takes your blood and looks at the glucose level, your level of glucose is a biomarker for your risk for diabetes. When they do a lipid panel and they look at your cholesterol levels, that is really a biomarker, something we can measure that tells us about your risk for heart disease and stroke. So amyloid and tau are biomarkers for detecting the amyloid plaques and the tau tangles. Well, how can we measure them in a living individual? And there's two ways we can do that right now. We can look at what is called cerebral spinal fluid, and we can also do what's called an amyloid PET scan. And in just the last couple of years, there's now a tau PET scan. In this model of the human brain, if I opened up in the middle, there's this cavity. It's right here. This is called a lateral ventricle. And in the back of this cavity, deep in the middle of the brain, is a structure that produces cerebral spinal fluid. And cerebral spinal fluid is a clear liquid. It's like water. This spinal fluid is produced here, and it flows out, and it flows around the brain. It helps to cushion the brain within the skull, and then it exits, goes around the spinal cord. And as this fluid sort of flows through the brain, it picks up these little fragments of amyloid. And by doing a spinal tap where you take some spinal fluid from the lower part of the back, you can measure how much amyloid is present in the fluid. This looks like most people sort of cringe when you show this. Our doctors do this probably about 5 or 6 cases a week. It's an outpatient procedure. What you do, you have the person lying on their side, sort of in a fetal position, use lanacane to numb the skin, and then there's just this very fine needle that is inserted between the vertebrae into the spinal cord where you can actually drip out a small amount of spinal fluid. The amount of spinal fluid we have in our brain at any given time is very small. It's only about 5 to 7 ounces for the whole brain and spinal cord. And you only take a small amount, but that spinal fluid is essentially replaced or replenished about 3 times during the course of the day. So if you take out spinal fluid, what you just ask the person to do is lie there for about 40 to 60 minutes, and usually that will revert any problems that they may have with headaches. So this is a common procedure. What we look for is, remember I talked about how the amyloid is sticking in the brain and forming these clumps. Well, when you look at the spinal fluid assay, what you see in patients with Alzheimer's disease is you see low levels of amyloid in the spinal fluid. And the reason why it's low is because it's not being cleared out. It's forming into these clumps. And you also see high levels of tau, because again, remember, tau is sort of the bullet that kills the cell. So as the spinal fluid moves through the brain, it's picking up sort of the remnants, the discards of that dying cell. And so you see high tau and low amyloid. In a normal adult, you see the inverse, because a normal adult is clearing away that amyloid, and they don't have much tau because the cells aren't dying. This amyloid and tau, they start in the temporal lobes, and then, as I said, they spread into the parietal and frontal lobes until in the late stages you see many areas of the brain affected. The other way, besides the spinal fluid assay, you can look at the deposition or deposits of amyloid using a type of a PET scan. It's called an amyloid PET scan. And this sort of shows the formation of amyloid in the brain in someone who has Alzheimer's disease, all of this sort of bright red and yellow, versus a healthy adult. These are just different perspectives of the brain, but you can see there's a clear difference between someone who has Alzheimer's and someone who is a normal adult in terms of where the amyloid is deposited.
Right. And these are procedures that are just done in research right now. So these aren't procedures that you could go in and ask your doctor for, but are in research to eventually be used in clinical practice. So let's talk a little bit about the difference. Let's learn about the terms dementia, Alzheimer's disease, and mild cognitive impairment. What do they mean? So, first of all, dementia is what we consider a syndrome. Dementia itself is not the disease, it's the syndrome. It's a collection of features. And the 3 primary features of dementia are, number 1, you lose intellectual ability. Number 2, it affects memory and other thinking abilities. So let's talk about that for a minute. What are some other thinking abilities other than memory? Shout them out, guys. Help me out. Calculations, what else did I hear? Problem solving, good. Short-term memory, long-term memory. Yeah, right now, yes, speech, language, very good. Right now, you're listening, you're listening. I'm talking, you're listening. What is that? Paying attention. Yeah. Let's see, what have we left out? I had to find my way here this morning. We all had to find our way here to the senior center, right? Has to do with direction. Spatial orientation, right, where we are in the world. Where we are in the world. Malcolm mentioned another one a minute ago, executive functioning, planning, organizing, multitasking. These are all considered thinking abilities. If you've been around a person with Alzheimer's disease, you know that over time they lose all these thinking abilities. So in dementia, you lose intellectual ability. It impacts your memory and all these other abilities we've been shouting out. And the impairment is so severe that you can't function anymore. You become increasingly dependent. At first, you might not be able to work or drive, and eventually you need help with your personal care. So dementia is that big umbrella term, and a good analogy is cancer is a big umbrella term. Because if you went to the doctor and your doctor diagnosed you with cancer, what would your next question be? Yeah, what kind, right? So if you go to the doctor and they diagnose you with dementia, your next question ought to be, what kind? It does make a difference to know what kind. We just know the most common kind or type is Alzheimer's disease, as you can see under the umbrella, accounting for 60 to 80% of all cases of dementia. Now, you could have dementia for other reasons we're going to show you in the next slide. Now, how do you progress from what we consider normal cognitive aging? And we're going to talk about this in more detail, but how do you progress from where I'm at now to having a full-blown dementia like Alzheimer's disease? Well, it's a slow, gradual transition. You're not falling off a cliff. This is very gradual and subtle, and there's a transitional phase called mild cognitive impairment.
One of the key things that you should take away that cognitive impairment can be due to a wide variety of causes. If you went into your doctor's office and you told the doctor, you know, I go into a room and I'll sometimes forget why I'm in the room, I don't think you would want your doctor to say, aha, you have a dementia. That's too big a jump. There's so many different causes. Some of them are irreversible, such as Alzheimer's disease. We don't have anything that'll stop it, but we have ways of treating it. Some are non-progressive. So, for example, if a person has a head injury or they have a single stroke in the brain, they may have cognitive difficulties, but it may not get worse. And then there are reversible causes of cognitive impairment. And some of the most common ones are medication interactions or depression. Oops. Other ones are metabolic disorders. So, for example, a person may be forgetful because they have a low level of vitamin B12, or they have a recently developed thyroid disorder. So there's many different causes, and you shouldn't immediately jump to the conclusion that any kind of cognitive deficit or memory problem is obviously Alzheimer's. It could be due to a lot of other things.
So, this is Dr. Alois Alzheimer, a German neuropsychiatrist. In 1906, identified Alzheimer's disease for the first time, identified the neuropathological changes, the plaques and tangles, in a woman named Augusta Dieter, who you see on the right side of the slide. Carl Dieter, a railway worker, brought his wife Augusta into Dr. Alzheimer in Frankfurt to the asylum and basically said, my wife's going crazy, because she was exhibiting all of those common signs of Alzheimer's disease, and particularly she was exhibiting some unusual behaviors of dragging sheets out in the street, of accusing her husband of having an affair, of hiding things under the bed. So Dr. Alzheimer followed Augusta Dieter for about 5 years, and at the time of her death, did an autopsy and found those plaques and tangles. Now, it's really sad that the only picture we have of Augusta Dieter, who was a typical housewife of the late 1890s, is a picture of her being very ill. One of the things she said to Dr. Alzheimer, which is written here in German, is "Ich habe mich verloren," which means I have lost myself. We tend to both forward and back these slides, so we're having competing remote controls. So, what's the story then? The story from 1906 to 2018. Well, up until the mid-1970s, we thought the primary cause of what in the old days we used to call getting senile, right, organic brain syndrome, if you've been around a long time, was arteriosclerosis, hardening of the arteries. Because Augusta Dieter was only about 55 when she died, everybody in the scientific community thought Alzheimer's disease is just this rare thing that happens to people under age 65. But if you start being confused as an older adult, developing dementia, that's arteriosclerosis, or that's getting senile as part of aging. Well, in the mid-1970s, to cut the story short, there were some researchers in Britain who looked at a whole bunch of brains of people who had been diagnosed with arteriosclerosis, dementia due to arteriosclerosis, opened those brains up, and found that in half of them were these plaques and tangles. And it was recognized that Alzheimer's disease is actually the most common cause of cognitive impairment in the elderly. We now know that Alzheimer's disease is the primary cause of dementia in at least 55% of cases. Dementia with Lewy bodies, which is another form of dementia we don't have time to get into today. Vascular dementias are the second and third most common cause. But what's really interesting is that in people with these types of dementia, there's often also Alzheimer's disease. So Alzheimer's disease is actually the primary or secondary cause of about 75% of all dementia.
Just to illustrate this, Cordula and I, at one point, a good number of years ago, we were at my father's house clearing away things, and I happened to find my undergraduate psychology book.
Your turn.
My turn to cough. And I had taken this undergraduate psychology on abnormal psychology in 1974, and the textbook was just published in 1974. And so out of curiosity, I said, well, I'm going to look and see what they say about Alzheimer's. And this was a book probably about an inch or more thick, and there was only one short paragraph on Alzheimer's disease. And it said essentially that Alzheimer's is a tremendously rare disorder affecting only young people, and that most doctors would never see a case of Alzheimer's disease. And I've made my career seeing Alzheimer's disease.
All right. Now that we're going to get our voices all straightened out again, we're going to move on to this issue of how Alzheimer's disease actually progresses or develops. Well, go ahead.
Well, I think we've got quite a bit of information to cover, so we'll be glad to talk about that maybe in the questions section.
Okay. So when we look at how Alzheimer's disease develops, first of all, we got to realize we could have Alzheimer's disease for a long time and not know it. So I'm 63. I could have Alzheimer's disease for the last 15, 20 years. I'm just not showing any symptoms yet, okay? So there are 3 stages in this disease progression. This, what we call preclinical, or asymptomatic phase that I just referenced, a silent part, mild cognitive impairment, and then the dementia phase. So all of us are going to experience changes in our thinking abilities as we age. There are normal to be expected changes. And these vary from person to person. They vary based on factors like genetics and education. But here's some common ones. It takes us longer to process new information. So we're giving you a lot of new information for you to take that in and absorb it. It's going to take it longer. It's going to take longer to learn and store that information. So you know that little wheel that comes up on the computer, if you've ever had an old computer, you know how that wheel spins and spins and spins, right? Well, as we get older, our wheels spin a little longer. It takes us longer to store that information. We're more susceptible to distraction. When I was a kid, I was really poor. Lived in a little farm in Oregon, and the living room where I had my desk to study and the family television were in the same room. And so I could study because I could put up an invisible wall and shut everything out. I could go in the zone. There's no way I can do that today. My brain isn't as good at shutting out all the distraction. So I'm lucky if I can have classical music on. Harder to recall information. Remember those faces we looked at? Some of you were probably going, oh, I know that person, right? But it wasn't popping up in your head what the person's name is. That's very common. And multitasking gets harder. So I used to be able to spin 15 plates at a time. Maybe now I'm down to 3. We've got to focus more.
So in the last 10 years, since 2011, we've had this concept of the preclinical phase that Cordula just mentioned. And this is where those amyloid plaques and tangles are starting to form in the brain, yet there's no symptoms. And this preclinical or asymptomatic phase can last for 10 as long as 20 years before any symptoms occur. Sometimes if there are symptoms, these are relatively subtle. And we refer to these very subtle subjective changes. This is where the person goes to their doctor and they say, you know, doctor, my memory isn't as good as it was in the past. I know something is going on. The doctor does some testing and they say, you know, Mr. Smith, your memory is fine. You scored in the normal range. But the person has a feeling that something is changing. This subjective cognitive decline is where the person feels there's a change, but there's no objective evidence for it. And sometimes this is due to this gradual accumulation of amyloid and tau in the brain, and sometimes it's due to other things, such as, such as depression or anxiety. It could be due to metabolic disorders. So there's many reasons for this subjective concern. It doesn't necessarily need to be Alzheimer's. But for those people who have the subjective concern plus amyloid in the brain, they have about a 4 times greater risk of converting to MCI or dementia down the road. If this amyloid still continues to accumulate in the brain, then eventually you go into the next phase, which is mild cognitive impairment. And mild cognitive impairment differs from subjective cognitive impairment because mild cognitive impairment is now where there is objective evidence of a problem. So the person does some cognitive testing and usually the individual will score in the bottom 10% of their peers. So in mild cognitive impairment, the person, the family, their colleagues, they are seeing a problem. Yet this individual is still able to function in their activities of daily living. It's sort of the analogy would be the absent-minded professor who keeps forgetting to pay the bills, forgets to pick up the items on way home from the grocery store, yet they can still function in most of their activities of daily living. Mild cognitive impairment is relatively common. In fact, the older we get, the greater the risk. And this slide shows that when you're looking at people in their early 60s, about 7% of individuals will have mild cognitive impairment. But by the time you get into your 80s, it's about a quarter of individuals will have mild cognitive impairment. I just wanted to also go back to the first slide, because mild cognitive impairment, it doesn't necessarily mean everybody will progress to dementia. In fact, only about half the people who have MCI will progress to dementia. Some will just stay the same, and some, actually about 15 to 20%, may improve and go back to normal. So MCI is certainly a risk factor for dementia, but not everybody will get dementia.
Oh, and then we go into dementia. So if MCI does progress, it will progress into dementia. And we've talked about dementia. It'll move through these mild, moderate, moderately severe, and severe stages. In terms of the length of time that it takes, we know that, whoops, we got to stop helping each other. We talked about you can have this disease for a couple of decades before you have any symptoms, right? Okay, so there's 20 years. When you start showing symptoms and you get into that MCI stage, it usually takes about 5 to 8 years if you're going to progress into Alzheimer's disease. And then it takes another 5 to 8 years to progress through the various stages of dementia. So Alzheimer's disease is a long, long disease, and in its entirety, we're talking about 3 to 4 decades.
So we often talk about Alzheimer's disease as a disease of the elderly, people over 65. But when you include the MCI stage and the preclinical stage, you can see that Alzheimer's disease is probably starting in the majority of individuals in their 40s or 50s. So the beginnings are much earlier than when the symptoms show up.
All right, so let's talk about diagnosis. If you are concerned, how do you proceed to get diagnosed? And it's really sad that among our healthcare community, our physicians still miss a large number of people in their practice who are cognitively impaired. And so I just want to say on that note, if you're concerned, if you think your doctor's not listening, you got to advocate for yourself. If you go to a specialty center like UCI mine, here's the commercial, they get it right 9 out of 10 times, right? So if you go to a specialist, and it doesn't have to be UCI mine, but if you go to someone who has specialized and is an expert in the area, you're going to get a good diagnosis in all likelihood. So you have a handout that has the 10 warning signs. These are really important. We're not going to go through them. If you have any of these warning signs, that should be of concern. You don't have to have all 10. You might have 1 or 2 things going on. Those are symptoms or red flags to pay attention to. Interestingly, too many people that have Alzheimer's disease are never told of their diagnosis. This is very interesting work that was done by the Alzheimer's Association in 2015, where they commissioned a study to go back and look at Medicare beneficiaries that had a claim related to Alzheimer's disease. So a billing claim. And those individuals who had a billing claim for Alzheimer's disease were surveyed and were asked, either they were asked if they could answer or their caregiver were asked, has your doctor ever told you that you have Alzheimer's disease? Only 45% of individuals have been told that they had Alzheimer's disease in their medical charts. Then they asked people with the most common types of cancer, the four most common types of cancer: breast cancer, colon cancer, lung cancer, prostate cancer. The same question, and 93% have been told their diagnosis. There's a big point here about people with cognitive impairment have a right to know their diagnosis and to be treated as adults. And so, again, there are so many misconceptions that feed into this lack of appropriate diagnosis. And the most common one out there in the public, but also amongst healthcare professionals, is that one, oh, you're 82, of course you would be getting a little forgetful, right? It's not just that your friends and peers might say that to you, but it might be an attitude your doctor has, and that's why you need to advocate and get to a specialist if you're concerned. Now, we live in a multicultural society here in Orange County and in Southern California, and among minority communities, we see beliefs like the person's going crazy, they're mentally ill, it's fate. Somehow it's your fault because you offended your ancestors, or even in mainline Christianity, we still have a problem with, you did some sin, right? It's the payback, God's payback. It's an imbalance between yin and yang. Some people still think it's contagious, and others think it might just be due to the stress of acculturation. None of these are true. And we work really hard in the community to try to get rid of these misperceptions so people receive an appropriate diagnosis and treatment.
So if you go to a specialty center, they will do a comprehensive workup. And really the purpose for the workup is to determine which of those syndromes we've talked about does the person fall into. So do they have normal aging? Are they having that subjective cognitive decline? Do they have MCI, or do they have dementia? And if they have dementia, what is the cause? Also, you can have multiple causes going on at the same time. So a person could have, say, MCI due to Alzheimer's, but they've also got depression. And they've also maybe got thyroid or a vitamin deficiency that could be treated. So you need to not only identify the syndrome, but you also need to identify what are maybe coexisting factors that could worsen or impair the individual. Typically, an evaluation would include multiple parts. And these include a detailed medical history where you want to find out what was the first symptoms, how did they progress, what is the person's medical history. You also want to do a neurological physical exam that would detect things like Parkinson's or maybe evidence of tumors. You also want to probably do some brain imaging. We've had many cases where an individual comes in and has not had any brain imaging. We had one individual coming from Chile. Family brought them up. This individual had been diagnosed with Alzheimer's disease because of memory problems, and they were getting progressively worse. We sent them for an MRI, and they had a golf ball-sized tumor in the left temporal lobe. And so the symptoms that looked like the beginnings of Alzheimer's were due to an operable tumor. So you want to do brain imaging to make sure there's not a tumor or a stroke or some other degenerative process. Then you want to do cognitive testing. Is there really a memory problem? So the person can say, "Doctor, my memory's shot." You do the testing and it turns out not to be the case. So you want to do cognitive testing to look at all of those different areas we've talked about: language, visual, spatial, memory, executive skills. And then you also want to do laboratory testing. Do they have a thyroid? Do they have a vitamin deficiency? Is there an infection in the brain? The types of imaging we talked about, the amyloid PET imaging and the tau PET imaging, and even the CSF test, those are not part of the standard diagnostic workup. But as we learn more and more in the near future, they probably will become part of the workup. Right now, an amyloid PET scan If you're rolling in money, you could probably get one. They cost about $4,000 to $5,000, but they're not reimbursed by any insurance or Medicare. But in the future, more than likely, they will be.
All right, just very briefly, because we want to take a break and talk about prevention. Let's talk about the medications that are available. Really important quote from Dr. Terriot there about dementia may not be curable, but it is treatable with medications and a lot of non-pharmacological approaches. So, you know, Alzheimer's disease was identified in 1906. You know that it was the 1970s before we ever even recognized that it was the main cause of cognitive impairment in the elderly. The first medication we ever developed was in 1993. It had toxic side effects, and so we developed better medications. The next one being Irreversible, then followed by two other drugs in this class called acetylcholinesterase inhibitors, Exelon and Razodine. In 2003, the last drug that we have was developed, memantine or Namenda, designed specifically for the later stages of the disease. Since 2003, there have been many, 250 or more agents and approaches tested in 400 or more clinical trials. And we haven't, you know, struck gold yet. But we've made, while I say that, we've made tremendous progress in our understanding of the disease, and one of the things we need most is for people to volunteer to participate in research so that we continue to advance the field. So these are the current drugs. I'm not going to go into them because of brevity of time. You have them in your handout. What I do want to say is the current drugs, you have to understand, are symptomatic treatment. We would all love to have a cure. We'd at least like to keep people stable over a long period of time. It'd be great if we could alter the disease progression, right? These drugs don't do any of that. What they really do is they boost your functioning. So they make your symptoms better, but when you're off the drug, you go back to where you would be in the trajectory of the disease. You're back on the natural progression. So, in the day, you know, in the day, meaning 35 years ago when Malcolm and I started doing all this, we used to diagnose people when they had full-blown dementias, and we are moving leftward. And as you saw in our presentation, we're getting to the place where we can identify the disease in the silent phase. And we think one of the reasons our drugs are limited is because we need to start treatment earlier. So, in other words, you don't wait to treat a heart attack or a stroke until you have it. You're treating the biomarkers. You're affecting or impacting the high blood pressure and the high cholesterol that your doctors give you medications for to prevent that heart attack or stroke.
So there's many clinical trials currently active. At UC Irvine, we have probably about 10 clinical trials. Many of the new clinical trials, what they're trying to do is they're attacking the disease, as Cordula said, in the early stages, not waiting until dementia is present, but rather focus on the preclinical or the subjective cognitive decline or the MCI stage. Because the belief is this is where you can really make a difference. And many of the drugs are looking at ways of removing that amyloid, either removing it or preventing it from occurring in the first place. All of these trials typically will do an amyloid PET scan at the beginning because they want to make sure the individual has amyloid and tau, and then they'll often do the intervention. It could be a pharmaceutical medication or it could be a lifestyle intervention. and then later do another amyloid PET to measure what changes have occurred in amyloid levels. And during the course of the trial, they also do measures of cognitive and behavioral functioning. So there's a number of websites that you can look on that give you information about ongoing clinical trials, and we've listed them on this slide. The UCI website also has a listing of the clinical trials we're involved with. So if you're interested in being a part of a trial, maybe trying to attack this at a very early stage, then I would encourage you to look at the information at our website.
We're going to talk about, right now, we're going to talk about 10 strategies to reduce your risk for Alzheimer's disease. And I'm going to start talking. And so hopefully you'll start listening. All right, these are the 10 strategies that we're going to talk about. We're going to walk right through them real quick. Sleeping well, eating better, exercising more, maintaining a healthy weight, flexing your brain, quitting smoking, understanding and taking your medications, treating depression, staying social, using hearing aids as needed, and most importantly, doing these things together. So first we're going to talk about sleep.
Remember how I talked about this amyloid is accumulating in the brain? Well, when we're asleep, the brain is surprisingly active. There's a lot going on in the brain, and one of the things that is taking place is that when we get into the deep stages of sleep, the brain is clearing out through that cerebral spinal fluid a lot of that amyloid. However, as we get older, the clearance mechanism slows down. So it takes about 2.5 times longer for a 90-year-old to clear out the brain compared to somebody who's in their 30s. If you don't go into the deep stages of sleep, so for example, if you have untreated obstructive sleep apnea, your clearance mechanism isn't really working, and so you're going to show a greater accumulation of that amyloid. So one of the best things you can do is try to get a good 7 to 8 hours of sleep at night. Unfortunately, only about 1/3 of Americans get 7 or more hours of sleep.
Also, talking about sleep apnea, we know that sleep apnea increases your risk for dementia. And so here's a study here that's referenced. And if you have sleep apnea, it's really important to use that uncomfortable CPAP machine, because it's really the lack of oxygen to the brain that occurs that seems to be the cause of the increased risk for dementia.
Right, because with sleep apnea, if you're always in the light stages of sleep, you don't go into that deeper stage where the clearance occurs.
All right, we're going to adopt some good sleep habits. Because of the brevity of time, you have a whole handout on sleep hygiene. We'd rather you adopted some good sleep practices than rely on these kinds of sleep aids. Go ahead.
Okay. Well, if you have to use a sleeping aid, if the sleep hygiene is not sufficient, then we would recommend using a natural hormone, melatonin. And you can buy melatonin just over the counter in health food stores and grocery stores. We would encourage you and your doctor not to use prescription sleeping aids, and particularly over-the-counter sleeping aids that have the label PM in them, because usually these PM means they contain Benadryl or diphenhydramine, and studies have shown that chronic use of these sleeping aids does increase the risk for developing cognitive impairment and dementia. Even short-term use at the regular recommended dose can cause cognitive difficulties, increased confusion in older adults, poorer memory, poorer attention. So if possible, use sleep hygiene and also if need be, melatonin versus these sleeping aids.
So we need to adopt a healthy diet for our brains. A lot of other reasons, but it's very important to your brain health. So what's your diet like? Are you eating brain busters? Is it full of sweets and fried foods and red meat? Or are you eating brain boosters, lots of fruits and vegetables? There are two diets that have been associated with reduced risk for Alzheimer's disease, the one being the Mediterranean diet. The Mediterranean diet, as you can see, involves a high consumption of fruits and vegetables, bread, cereals, potatoes, beans, nuts, and seeds. Also, the primary source of fat is olive oil, dairy products in moderate amounts, little red meat, and wine in moderate amounts. The other diet that has been associated with reduced risk is the MIND diet. The MIND diet has some very similar characteristics. You have to give up all that butter and cheese and fried foods and stick more to fruits, vegetables, nuts, eat fish regularly. You have copies of these diets, and that's why I'm not going into them in detail. But there was a really interesting study that was done, and this involved 923 individuals that were followed over an average of 4.5 years. The researchers wanted to figure out which diet was best for your brain. Was it the Mediterranean diet, was the MIND diet, or was it the DASH diet, the dietary approaches to stop hypertension, so a diet for heart disease? And they found that individuals who really stuck to either that MIND diet or the Mediterranean diet reduced their risk by over 50%. Now, if you only kind of so-so stuck to the diet, the MIND diet outperformed the Mediterranean diet. You still reduced your risk by a third.
Not only did the MIND and Mediterranean diet reduce the risk of developing dementia, but also people who follow the diet have better cognitive abilities. In fact, being on the diet, an individual would be scoring about 7 years younger in terms of their age.
I'm sorry?
Okay. More recently, the MIND and Mediterranean diet have also been shown to have rather wide-ranging benefits. The Mediterranean and MIND diet are well known for the benefits for reducing cardiovascular disease and stroke, but more recently, some research has shown that this Mediterranean MIND diet can be helpful for treatment of depression, not as a primary treatment, but as an adjunct. And also, just at the American Academy of Neurology meeting this year, there was research presented that the MIND Mediterranean diet, with the emphasis on fruits and vegetables, may actually lower the risk for developing Parkinson's disease. And individuals who have Parkinson's disease, it may help slow the progression. So this diet is a heart and brain healthy diet that has wide applicability.
So we want to make sure that we're eating fish on a regular basis. We know that eating fish just one time a week in this very classic study reduced risk by 60%. You can think about 1.0 as kind of a baseline level of risk, and you see that people who were eating a meal that involved fish, so it could be as simple as a tuna fish sandwich prepared in a healthy way, had a 60% reduction. So cold water fish, salmon, mackerel, tuna, sardines, best source of omega-3 fatty acids. It's really important to understand that our brain relies on these omega-3s, but our body doesn't produce them. So you have to consume them.
An interesting study was done where they looked at normal, healthy adults and their intake of fish, and they followed them for 10 years with MRI scans. And what they found is that the people who had fish as a regular part of their diet showed a greater volume in the frontal lobes, and remember the frontal lobes are involved in these executive skills, judgment, planning, as well as a 14% increase in the plumpness or size of the hippocampus. And so again, this is just through having fish either grilled or baked as part of your regular diet.
The big concern about fish always is contaminants. So you can go onto a website like mercury.org and you can find out what fish has the least contaminants. We know that farmed salmon has more contaminants than wild salmon, but that farmed salmon that's from Chile or Washington State has the least amount of contaminants. So pay attention to where the fish is from. But honestly, the best way to get rid of contaminants is to skin the fish before you cook it. Most of the contaminants are in the skin. We also need to talk about alcohol consumption. Just a moment ago, we said the mind and Mediterranean diet both allow for a little wine, a little alcohol in moderation. But what is in moderation? So here's what's in moderation. 1 drink per day for a woman, 2 for a man. What's a drink? A drink is 12 ounces of beer, 8 ounces of malt liquor. You can see the different levels of alcohol, 5 ounces of table wine, and 1.5 ounces of 80 proof spirits. The evidence on alcohol and the being able to drink and how beneficial that is for your brain, there's 2 sides to this coin. While a little red wine might be good for your brain, we know that from a very recent study that looked at 3.2 million medical records in France, that alcohol abuse or misuse more than triples the risk for dementia in both men and women. And what was interesting in this study was that the individuals who had an early onset form of dementia, meaning before age 65, over half of them had some kind of alcohol issue or alcohol use disorder. So let's talk about vitamins and supplements really quickly. The question is always, well, can I just eat all this in vitamins? I'll just keep taking my statins, I'll take all my vitamins, and I'll go out and eat French fries and sweets. No, it doesn't work that way, folks. The research about just taking vitamins instead of eating or getting your nutrients from foods is very mixed. And bottom line, most of the research that shows benefits for the brain does show consumption through food. So, yes, Malcolm and I both take our vitamins, but we also stick pretty much to a mind-type diet, right? So we got to be careful, too, with vitamins because they can have a lot of risks. They can interact with your prescription medications. So just as an example, vitamin E is a blood thinner, so if you're taking Coumadin, you shouldn't be taking vitamin E, or what amount you take should be monitored by your doctor. Vitamin E can also increase risk for death. So bottom line is, there's no magic bullet here. You got to work at it. So back in the day, in the Old West, they used to have brain salt. We always were looking for a magic potion to cure our troubles. In this case, brain troubles, headaches, seasickness, and so forth. Well, we're still looking for the magic potion, and if you're an older adult, you're probably being marketed too heavily for one of these memory supplements, which is now a $2.7 billion industry. There were $2.7 billion in sales in 2016. So let's take a look at whether you really ought to be spending your money on this stuff.
Well, these supplements are not monitored or approved by the FDA. So really, if a company puts some disclaimer into their advertisement, they can market just about anything. The real question is, do these things help? Because we get a lot of questions, like people say, I take that thing that comes from the jellyfish, that lights up the jellyfish, is that good for me? Well, the TV commercials, they say the #1 seller of brain supplements in the United States. It doesn't say anything about their effectiveness. It just says that the company has a good marketing strategy. In fact, the company that makes that jellyfish was sued by the Federal Trade Commission for deceptive advertising. Most of these supplements have never been tested in a rigorous clinical trial, where you have a control group and an experimental group, and the examiners are blind to knowing which group an individual is in. So those are double-blind, placebo-controlled trials. Most of the evidence the companies spout for these benefits come from testimonials. And you never see negative testimonials in the commercials, where they say, oh, I wasted $60 on this and it was worthless. They only show you the positive testimonials. The Prevagen makers, they did do a trial. They don't talk about it too much, but they actually had a control group and a group given the Prevagen, and they had them tested on 10 computerized cognitive tests, mainly of memory. And lo and behold, the Prevagen group did show an improvement over time on these tests. But the control group, who weren't getting anything, they showed a similar improvement over time. So there was no statistical difference between the groups. Prevagen and a lot of these others, they're not cheap. You can be spending anywhere from $60 to over $100 a month. So I think it would be much more worthwhile just to use that money to get a nice salad and fish dinner and go for a walk.
That's right. Oh, and we got to move. We got to move our bodies. We know that exercise is so beneficial to the brain. And in fact, look at this. 13% of all cases of Alzheimer's disease worldwide is attributable to sedentary behavior. Researchers have estimated that a 25% reduction in sedentary behavior could potentially prevent more than 1 million cases globally. So sedentary behaviors are associated with increased cardiovascular and metabolic risk factors. We're going to be talking about those, cardiovascular disease and diabetes, in a minute. And they also appear to have direct neurobiological processes. So sedentary behaviors also seem to affect neurobiological processes such as neurogenesis, or the birth of new brain cells. So
we've known for a long time, 15, 20 years, that people who exercise have a reduced risk of developing Alzheimer's and other forms of dementia, particularly if the exercising starts taking place in midlife or earlier. So if you're young, like some of the nursing and medical students, if you start exercising, it will actually help protect your brain when you're in your 60s and 70s. We also know that even if you start exercising when you're in your older age groups, 70s and 80s, you will show a reduction in risk of developing cognitive impairment and dementia. It can be as much as 40% reduction in risk. Not only does it reduce the risk of developing MCI and dementia, but also people who exercise score better on cognitive tests, and they do better in their day-to-day functioning.
So what kind of exercise do you need for brain health? Well, this was an interesting study and found that aerobic exercise, resistance training, or a combination of the two, Tai Chi, all beneficial for cognitive functioning. But it needs to be moderate to vigorous physical activity. So you really got to get moving, and optimally, you're doing this for about 45 to 60 minutes most days of the week to get the greatest benefit. But if that all sounds like too much to you, the bottom bullet is the most important. Any exercise is better for your heart and your mind than no exercise at all. Because that's often what happens is, if you can't go out there and run for an hour, you say, I'm not going to do it at all. So you got to do whatever you can do.
A lot of people say, well, what do you mean by moderate to intense exercise? What the description is, where you see the benefit is this green and also this. But if you can get to the green, what this means is that when you're exercising, your heart is beating faster and maybe you're starting to break a sweat. That is where you see the benefits of exercise. A lot of people tell me, oh, I do a walk, I go with the dog twice a day, we go for about a couple of blocks around the home. And I ask them, well, tell me about your walk. And they say, well, the dog stops every 10 feet or so to sniff the flowers. And they say, sometime my wife comes with me and we'll sing. So that is not going to be vigorous enough. If you can walk and sing your favorite songs, you're not walking hard enough. So you need to be walking where your pulse is up, you're starting to break a sweat. You can talk, but it's going to be a little hard to talk. If you can get to the intense where you're actually having a hard time talking and walking, then that's even better. But at least try to get to that moderate intensity.
So Malcolm already mentioned starting early is very beneficial. This particular study showed that if you were exercising in midlife, you reduced your risk by 62% to developing a dementia in older adulthood. And combining strategies is really important. This is just one study, but it looked at people who only followed the Mediterranean diet versus those who only did exercise versus those who followed both the diet and did exercise. And guess what? The greatest bang for your buck is when you did both, with a 60% reduction in risk. We're going to talk about maintaining a healthy weight very briefly. I'm sure you're all familiar with body mass index, BMI. That's a measure of body fat based on your weight and your height. You can go online, it's very easy to calculate your BMI. You want to be in that healthy range of 18.5 to 25. And this is a measure that's often used in research that looks at reducing risk for Alzheimer's disease. So these are two very interesting studies. Both of them showed that being obese young really increased your risk. And the older you were, as each decade passed, if you were obese, by the time you got to 70 to 79, it didn't affect your risk for Alzheimer's disease. And by the time you were 80, if you were a little overweight, it actually reduced your risk. Similarly, this study in which individuals, and you can read the details, but they were on average 55 years old, if they were obese, they had a 29% lower risk, while those who were underweight had a greater risk. So this is very confusing, and there was a recent study, just very quickly, the vertical line here represents BMI going from underweight to obese. This line, the horizontal line here, shows the point of dementia diagnosis and the years before diagnosis, so 30 years before diagnosis. Well, if your ideal situation is you're going to maintain a healthy weight throughout your life, Now, these researchers looked at the trajectory of weight, so how do weight change in people with dementia over this time span? And they found that people who developed dementia had issues with obesity out here 20, 30 years before, but then as they were getting closer and closer to dementia, those 10 years before, there was a significant decrease in weight. That actually might be related to the actual disease process. So it's a complicated relationship. So maintaining that healthy weight in midlife is very critical. We're going to talk about flexing your brain. TV viewing, not a good deal, being a couch potato. Just briefly on this study, they looked at people and they asked these older adults, some of whom had Alzheimer's disease and some who were cognitively normal, how much time did you used to spend watching the TV? Well, those people who developed Alzheimer's disease spent over a quarter of their leisure time watching TV. Now, every extra hour increased risk 1.3 times. But if you switched that TV watching out with something mentally stimulating, it reduced your risk. And a similar study that followed 18 to 30-year-olds, they followed them for 25 years. Those who spent a lot of time watching the TV and had low physical activity had poor cognitive functioning. So a lot of people ask us questions about, does this help? I do crossword puzzles, I do Sudoku. Does this really make a difference? And in this study, the researchers looked at all of these everyday activities that people do. And yes, people who engaged in these kinds of mentally stimulating activities were at a 43% reduced risk for developing dementia. So it doesn't necessarily have to be this.
So with these brain games, and there's various makers like Luminosity, Posit Science, they advocate sort of using their games as a way of helping to maintain or improve your cognition. Well, what's the evidence for it? Well, it's rather sparse. We do know that if you play these games consistently, you will get better at playing those kinds of games. It doesn't necessarily carry over into your day-to-day life. Some of the games, particularly those that tap into complex visual, spatial, and attention, they actually have been shown to improve our driving ability, our ability to detect vehicles in our periphery and to respond quickly. But it's probably better in the long run that you keep active by being around others, joining in group activities, going out and socializing with friends, going to the movies, going to the theater, going out to dinner. So probably if you can keep yourself active socially and mentally, that's probably the best strategy for you rather than maybe doing these games. The key thing is that you need to do things that challenge your brain. A lot of times people will say, I do crosswords every day. Well, crosswords is a good way of challenging your brain. However, if I ask them, do you find it challenging? Oh no, I can almost do it in my sleep. In that case, it's not really helping them. It'd be much better for them to do something that causes them to think in a different way, to somehow learn a language, learn a musical instrument, take up painting, something that causes them to think in a different or challenging way.
All right, so a little bit on smoking. As you can see, 14% of all cases of Alzheimer's disease are attributable to smoking. And there are many factors that increase risk for dementia, or why smoking increases risk, that are listed on this slide, including the fact that smoking increases your risk for cardiovascular disease and diabetes and stroke, which are all risk factors for Alzheimer's disease, narrowing the blood vessels, and causing oxidative stress in the brain. Understand and take your meds.
The two main things you need to be attentive here are your blood pressure and your cholesterol. Those are the two major cardiovascular risks that most older adults have to deal with. This is a chart just showing the what is the ideal blood pressure and also what is considered to be hypertensive and hypertensive crisis. You need to work closely with your doctor to determine what is your ideal blood pressure. Why is this important? Well, increased blood pressure.
Whoops, that went too fast. I think we both clicked at the same time again.
Poorly managed hypertension increases the risk for dementia 3 to 5 times versus people who have normal blood pressure. Most people, at least 1 out of every 3 Americans has hypertension. And of that 1 out of 3, about a third of them don't even know that they have high blood pressure. So it's important for you to get your blood pressure under control and to be monitored by your doctors. Just out of curiosity, how many of you sort of regularly take your blood pressure? Okay. Oh, not too, it's only about a third. Okay.
All right, and this just details what Malcolm said about increasing your risk 3 to 5 times. And the higher your blood pressure, the higher the risk.
So how many of you have a good idea on what your cholesterol levels are, your LDL and HDL? Oh, probably at least 60% of you seem to do that. So you know then that the LDL is the bad cholesterol. This is the cholesterol that sort of clogs the arteries, restricting blood flow. And the HDL is the healthy or the beneficial form of cholesterol that helps to remove the bad cholesterol from the artery walls and process it and helps get rid of it in our body. Why is cholesterol management important? Well, individuals who have high cholesterol, they have a 2 to 3 times greater risk of developing cognitive impairment and dementia. And if you often have hypertension and high cholesterol going together, in that case, it also increases it even more, up to 3.5 times. So these are 2 important things that you can work with your doctor: hypertension, your blood pressure, and your cholesterol. And by working on those are actually pretty easy ways of reducing your risk.
Also want to mention that diabetes is a significant risk factor for Alzheimer's disease, and I'm sure you've all had fasting blood tests where you have to fast for 12 hours before you go in. We know that the cutoff for diabetes is, in terms of your glucose level, is 125 milligrams per deciliter. What the studies have shown is that type 2 diabetes, this is type 2 diabetes, is diabetes we develop often in later life, in which our bodies either are not using insulin effectively or they're not producing insulin that we need. And in this review, there was a study that did a review of 16 other studies. You can see that the risk was 1.5 greater risk for Alzheimer's, 2.5 for vascular types of dementia. This is a big problem because we know that half of Californians are pre-diabetic. Why do you think that is? Go back to the diet, right? It's all the French fries, it's the obesity. So sadly, the obesity epidemic that we have, when we look around us at young children, may lead to an increase in dementia in their later lives. So here's just another study showing that women who are diabetic have somewhat greater risk than those who are men. We're going to treat depression.
Depression is getting more and more attention, depression and anxiety. And the relationship between depression and anxiety and dementia is complex. Remember how we've talked about how Alzheimer's disease has this long preclinical stage where there's changes in the brain? So we often will see problems with depression and anxiety occur many years before the onset of cognitive changes. Does this mean depression is a risk factor for subsequently developing dementia, or is anxiety and depression one of the very early changes resulting from these brain changes? So the way to look at it is you need to go back probably 20 or more years before any cognitive changes occurred. And there is evidence, again, it's controversial, that having depression, particularly long-lasting depression and anxiety particularly, are perhaps risk factors for developing dementia later on in life. We don't know if treating the depression and the anxiety will prevent the person from developing cognitive impairment later on. So it's really still very controversial, the relationship between mood disorders and risk for dementia. Is it an early sign or is it a risk factor?
So this is the painting at Eternity's Gate by Vincent van Gogh, and you may all know that this famous painter committed suicide, and I think that this painting portrays that desperation of depression. And Malcolm just raised the question, does depression increase risk, or is it one of those preclinical signs? Well, from a treatment perspective, whatever it is, we should treat it. And we need people, again, to receive either the medications or the psychotherapy and counseling that they need to deal with depression.
And depression is very common in older adults, and it's often missed. Many of the symptoms that you see in an older adult aren't necessarily the tearfulness and crying, but they're symptoms such as a withdrawal, sleeping problems, appetite changes, not wanting to be with family or friends. And so sometimes this is just attributed to the aging process, but that's a mistake. So if there are symptoms of depression, even though they may not be tearfulness, those should not be neglected.
So stay social. Here's a whole series of studies beginning in 2000 showing that the more social you are, the more engaged you are, the richer your social network, the better it is for your brain, okay? So you've got all that data. So when we think about protecting our brain, and this is from a large study that was just done, we gotta stay socially connected. We know that lack of social connection increases our risk. And there's a lot of ways to stay socially connected these days, including social networking and having frequent contact with those that are important to you. Also, living alone is a risk factor. And so you might consider how you would live with others, be it in a typical retirement community, or be it in a village, or be it in some kind of co-housing. And loneliness, additionally, is a risk factor. So we need to guard against loneliness and social isolation in our older adults. And we need to use hearing aids if we are having difficulty with our hearing.
Hearing loss is pretty common as we get older. About 10% of individuals in their 40s and 50s have some hearing loss. That jumps up to about 30% for people in their 60s, and it's as high as 70% for people in their 80s and above. And we know that hearing loss increases the risk for dementia considerably, particularly if the hearing loss starts in midlife and is not corrected. Why is that? Well, if you think about it, if you're not hearing what other people are conversing, you're becoming more and more isolated, so you're probably not necessarily going to be involved with them. That's related to what Cordula just mentioned about being isolated and not connected. If you're not hearing the information, you're not getting enough brain stimulation. And so these things get progressively worse the longer the hearing is not addressed. So it's important, if you have a hearing loss problem, to get it corrected.
So let's go back. We're going to get 7 to 8 hours of sleep, right? We're going to eat a healthy mind or Mediterranean diet, fruits and vegetables. We're going to get out there and get some moderate to vigorous physical activity on a regular basis. We're going to watch our weight. We're going to challenge our brains, right? Learn something new. If you're smoking, you're going to stop that. You're going to make sure you're paying attention to your overall health, particularly any cardiovascular risks or risks related to diabetes. You're going to treat depression if that's an issue. You're going to stay socially connected with others. And if you need to, you'll use hearing aids, and you'll work at this and you'll combine these strategies so you protect your brain to the maximal level. So UCI Mind. It's one of 30 NIH-funded Alzheimer's disease research centers in the U.S., the only one in Orange County. It is also one of the California Alzheimer's disease centers and the only one in California. And it involves world-renowned, internationally known researchers from 10 schools and departments on the UCI campus. You can all get involved. You can advocate. We need people to advocate to continue to increase funding and effort on this disease and to help the families that are affected. You can donate, and Linda Scheck's here, who's the Director of Development, right there. Linda, raise your hand. And support the work that's done at UCI Mind. And you can participate. One of the most important things is to participate in the ongoing research.
And we have opportunities for both healthy adults to participate in research as well as those with mild cognitive impairment and dementia due to various kinds.
So let me see. And if you are interested, you can sign up for the UCI C2C registry. So you basically are on a list, and as studies can't come up, you may be invited to participate in those.
And I think if you're interested in, you can just go to the table at the back. They have some tablets where you can sign in, or you can fill out a form that just says, I'm interested, please send us information about UCI Mind and studies. So
all right, you've been a great audience. We just have a few minutes left for questions. Does anybody have some burning questions? Yes, ma'am. I'll let Malcolm do the brief version, Malcolm.
Well, Lewy body is probably the second most common cause of dementia after Alzheimer's disease. Robin Williams, he had Lewy body dementia when he committed suicide. Casey Kasem, American bandstand, he had Lewy body dementia. But Lewy body dementia has some features that are similar to Alzheimer's in that it has similar cognitive problems with memory, particularly visual spatial difficulties. But the key features that you look for are, you look for the presence early on of very detailed, recurrent visual hallucinations. These are usually of people, insects, or animals. Parkinsonian motor changes, that's the second feature. This includes things like rigidity or slowness of movement. You don't often see the tremor you see in Parkinson's disease in Lewy body patients. The third feature is they will show what is called REM, or rapid eye movement sleep behavior disorder. And this is where the person acts out their dreams when they're asleep. Usually when we fall asleep, we lose our muscle tone. So sometimes you'll have a dream like you're being attacked and you're trying to run and your feet are encased in lead boots and you can't move. That's because you lose the muscle tone. Well, with Lewy body disease, patients retain their muscle tone, and so they can actually sit up in bed, punch, jump out of bed. So if we see REM sleep behavior disorder, Parkinsonian motor signs, and visual hallucinations early in the disease, then that raises the possibility of we're looking at Lewy body dementia. Lewy body dementia also has somewhat different biomarkers than does Alzheimer's disease. It's got another type of a protein called alpha-synuclein. Treatment for Lewy body is very similar to what we use for Alzheimer's disease, but there are Lewy body websites and the Lewy body support group, which I don't know if you're aware of that, but anyways, if you have a member who has Lewy body, the Lewy body National Association has support groups which could be beneficial. Lewy is L-E-W-Y, and then body, B-O-D-Y.
Yes.
Why do you think doctors do not tell their patients that they have Alzheimer's?
I think research has indicated that there are a lot of reasons that contribute to that. I have to say, physicians are human beings. Alzheimer's disease is the most feared disease among Americans 60 and older, and a lot of physicians are uncomfortable with talking about Alzheimer's disease. They may not have been trained to do that. They may be unsure of the diagnosis, and the healthcare system also doesn't promote identification simply because there's not a lot of financial incentive to identify Alzheimer's disease and to do this in the context of 10 or 15-minute appointments. So those are just some of the reasons that contribute. Yes? Big word, I couldn't. Oh, is a general practitioner adequate to diagnose MCI? I can't make a general statement. I think that one of the things that the Alzheimer's Association, Alzheimer's Orange County, and other organizations like that, including UCI Mind, are attempting to do are to educate physicians so that they continue to increase their skills and ability to diagnose MCI. I think if a physician does not feel that they have the knowledge, ability, or time, a referral to a neurologist is what would happen if there's a concern. Yes, ma'am, over here. I have to go to this side of the room. Yes, let's start back there, yeah.
Would you speak about FTD or Pick's disease?
Frontal temporal, it's called FTLD, frontal temporal lobar degeneration. And it's really a group of two disorders. One that's called FTD, behavioral variant, which is where the main and earliest symptom are changes in personality and behavior. And the other is called primary progressive aphasia, which is a group of language disorders. And so this FTD accounts for maybe somewhere between 6 and 10% of dementia in people over age 65. It's much smaller than Lewy body and much smaller than Alzheimer's. But the big thing that most people are familiar with the behavioral variant is it's a dramatic change in behavior. And this is because the changes in the brain are really isolated into the frontal lobes and the anterior temporal. And as a result, you get a lot of behavioral changes such as disinhibition, where a person who's normally quite socially appropriate starts telling dirty jokes or touching people inappropriately. They can also become very apathetic, loss of interest in families and friends. They may become increasingly agitated and irritable. So there's a lot of personality changes where sometimes families say, well, he's 180 degrees different from how he used to be. So if we see very marked personality changes early on, that could be an indication, particularly if the individual is young, under age 65, that this could be FTD. The language changes, there's different kinds of language changes, and these are all producing difficulty in the production of speech or comprehension of speech. Most cases of frontal temporal lobar degeneration occur young. In fact, the average age of onset is in the early 50s. Compare that to Alzheimer's, where the average age where you start to see the dementia is typically in the 70s. So the behavioral variant is the most common form, but you can also have language variants as well.
All right, now we'll go here, blue, in the blue there. Yes.
At the beginning of your presentation, you gave statistics about how Alzheimer's is becoming a more and more cause of death. And I clearly understand how Alzheimer's is becoming living more difficult, but I still can't rationalize or understand how Alzheimer's increases death.
Well, Alzheimer's disease is a terminal disease, and if you live through the entire disease, you don't die of anything else. You don't die of cancer or heart disease along the road, and you live to the most advanced stages. The disease shuts your body down, just like any other disease. And you will start to develop you will become totally bedridden. You will start to develop swallowing problems. Your brain is continuing to be destroyed, the brain that controls these functions, and so it is shutting your body down. And at the end, because your body is shutting down, you might become very susceptible to an infection like pneumonia. But what you died of is Alzheimer's disease. That's what caused your body to shut down totally. Yes, in the pink?
If you're taking omega-3, the omega-3 and omega-6 also show
Omega-6 as good as omega-3s.
Well, I think the literature suggests it's the omega-3 that is probably the more beneficial with the DHA,
DHA and E.
DHA and E.
Yeah.
There, years ago, when I was seeing patients, and 20 years ago, there was a lot of attention given to supplements, particularly vitamin C, vitamin E. And I think over the last 10 years, people have trended away from looking at supplements and rather looking at the diet.
Right.
And so I think the evidence is better that you get your omega-3s from your diet, the fish, than taking fish oil. Now, fish oil can be used. If people just are aversive to eating fish, fish oil could be beneficial. Fish oil also is often used for helping to manage high triglycerides. It can lower high triglycerides. So some people are using fish oil not necessarily as a substitute for eating fish, but maybe as a way of attacking these lipids in the fat or the blood in the.
Okay, there was a gentleman in the, yes, turquoise-like shirt, yes. If you have go ahead.
Well, I think if you have a first-degree relative, a parent or a sibling with the disease, we know that it probably increases the risk about 3 times. But you need to put that into context. So what is the average risk of everybody to develop Alzheimer's? We showed you it's about 1 in 10. So if you have a parent or a sibling, your risk doesn't mean you go from 0 to 100%. It means you've gone up 2 or 3 times greater risk. But I think the important thing is what we talked about in the end here, the lifestyle things you can do to reduce your risk. So if having the gene, well, this is separate from the gene, but if you have a parent who has Alzheimer's disease, It may double to triple your risk, but we've just showed you that if you're an exerciser, you can reduce that risk by 40%. If you're eating a healthy diet, that's going to additionally decrease your risk. So I think that the lifestyle factors can often outweigh if you have a first-degree relative with the disease or not.
Okay.
I just wanted to go back about the omega-3 fish oil. Again, as Cordula said, you need to talk with your doctor if you're going to start using fish oil, because fish oil is also a blood thinner. And so if you're using any supplements, you need to sort of run it by your doctor and make sure it's not going to interfere with any prescription drugs.
As I always say, do not leave this presentation and go to CVS next to buy supplements. Talk to your doctor. Was there any other questions on this side? I know I was, yes.
I remember a few years ago that we had a time of sitting in medical school on all these diseases about 1 hour. Has that changed?
Oh, I couldn't tell you specifically how much time is spent in medical school. There certainly is not enough time spent in medical school on the needs of older adults overall, as well as specifically Alzheimer's disease. So I'm going to respect everybody's time. It's 10 after 12 now. You've been a great audience. Please fill out your evaluation forms, and we'll be here for a few minutes.